Well, hello, and thank you for joining me today. I've got a very special and important guest for us today to have a really very important discussion about how children breathe and sleep. Today with me is Dr. Audrey Yun. Doctor, thank you so much for joining me.
Oh, thank you so much for your invitation. I feel so honored, and I'm so looking forward to having a great time today.
Yeah, definitely. We've been talking a little bit about getting together for a discussion on these issues. A lot of people out there today are experiencing the a lot of the issues that associate with how children sleep and breathe now, and there does seem to be this connection between how the dental arch develops. And you as an orthodontist has been someone that's working in this area in with quite a lot of detail in the last few years, and there's a body of literature we're going to talk about, which I'm really excited to. But I thought before we started, you could help the audience understand how you began this journey into, from as a board registered specialist orthodontist into understanding this world of sleep breathing and how you began to think about that.
Yeah, it's a long story, and there's a lot of incidental meeting with the great people. So, where should I start? I mean, originally I was very into aesthetic aspect of medical field. I don't know, you remember the show like Extreme Makeover, The Swan in US, and also there's a show like Let Me In Korea. Now it's a global program, and I graduated from Seoul National University Dental School originally in Korea. And during my dental school, I grew interest in orthodontics, giving people beautiful smile, so cool. And also I went into the orthodontic surgery field. Jaw surgery has to be combined for these extreme makeover cases, and that give you really life-changing moment. So I wanted to move to US to study further. But still, even now, the aesthetic is still my core value. And when it comes to treating my patient, at the end of the day, my patient has to look beautiful, period. And even all this, thinking of the airways issues, if you actually get the airway correctly, your patient gonna look beautiful. So I went to the UCLA. I went to US, and I went to UCLA for dental school again, and I did orthodontic residency and pediatric residency there. But during my residency, I met Dr. Pei and Dr. Harper, who is huge in sleep apnea brain research at UCLA, and I became fascinated to sleep apnea. So I ended up doing my master's degree specializing in obstructive sleep apnea. But even that time, I didn't know how to connect the orthodontics and sleep apnea together. But the most important moment was I met my surgeon, Dr. Stanley Liu. He found me because I had a strength in orthodontic surgery and my background of sleep apnea research. So I started collaborations with the Stanford Sleep Surgery, and I started treating this sleep apnea patient every day. And I mean, by the way, Dr. Liu is amazing, bright, like most complete surgeon I've known. So you should interview him soon there as well. But Dr. Liu, I've been very open to new ideas and integrating to our practice, and how we can improve our surgical success, how we can move our field to next level. And still, even now, the sleep medicine field is very much in its infancy. And during my Stanford collaboration, I have my life-changing moment, which I met my mentor, Dr. Christian Guillermino, who is the godfather in the sleep apnea. For the people who doesn't know, he's the one who found the sleep apnea, found the pediatric sleep apnea, named it sleep apnea, categorized it, invented like a AHI index. He also brought the MMA surgery to sleep field. It's basically he made this field up to now. And now, I mean, unfortunately, he's in heaven, but I miss him so much. But he was my inspiration. Past years, his passion was to look for preventive treatment for sleep apnea. He has a pressure me that, Audrey, you need to come up with a growth modification protocol for children. And like, doctor, there is not that much evidence. People not gonna, believe in me. But no, you need to help our kids. Imagine and come up with a new idea. Try them to see if it works. And the power of imagination gonna transform our field from like treating disease to preventing them. And I mean, he had many brilliant ideas. He encouraged me to find more reliable way to grow the maxilla for all ages, like from very young ages to even adult OSA, where we designed, we call DOME, the distraction osteogenesis maxillary expansion technique. And now that technique is still evolving every day. And CG also asked me to look for frenulum research, and like you need to find the missing puzzle of this sleep apnea relating to frenulum. There was maybe genetic component. You need to do saliva research to look at for the frenulum. You need to find the missing puzzle. And I mean, now a lot of my current research are very clinically oriented. Now I want to find the answer for my clinical question in my everyday practice. And like I see the relationship between clinical finding, like, oh, after expansion of palate, patients' parents is saying that, oh, my kids stop snoring. Oh, when I see some high arch palate, I often see, they have a short frenulum. And, with my clinical experience, I can hypothesize like, oh, this relationship, but, myself, I want to know this really related. And if then why? There is a huge lack of evidence and research in this area. And there is not that many good paper with the high impact factors, peer review journal. And, there is no consensus among clinicians, even from very basic questions. So, beyond this anecdotal evidence, we need to have more concrete evidence to connect this dot to have more comprehensive understanding and insight. And eventually we want to set up the new standard of care. And in order to accomplish that, I really need mainstream scholars' help. So now my passion past few years is to raise awareness of sleep disorder breathing in each specialty in mainstream and push these mainstream scholars to open their heart and work together to move this field to the next level. And I'm so excited to see the change of our residency program curriculum. In the past, our traditional orthodontics and pediatric residency was very close. Now I teach the dental sleep medicine course for UCLA, University of Pacific, UCSF resident. Now it's a part of curriculum. And we are launching the Dental Sleep Medicine Fellowship under University of Pacific Orthodontic Department for Orthodontics. So our new orthodontic fellow will board certify for dental sleep medicine, and will learn how to treat this sleep apnea patient as orthodontists, and going to be new ambassadors in this field. And I hope I can share this exciting news officially very soon, but it's a very exciting time.
That is really exciting because, as you say, there has been a big gap in the understanding of what clinicians are seeing in the practice and what they can actually do about it, and then what the literature says, and guides us as to, how we understand and treat these conditions. So it really is a very, very important piece of work that you're doing. That was why I was so excited to interview you, and it's great to see that Christian Guillemeau's work is just flowing out beyond unfortunately beyond his passing, and that this is all happening. And so it's a really amazing story, really, that we're beginning to see this flow out into the world of how clinicians can actually help patients with this. I wanted to just quickly, because I find this really interesting, the connection between beauty and orthodontics, and how you see, if you can just give us a little bit of an overview before we dive into the sleep world, because I really like this idea between aesthetics and how we grow and develop, and then the connection to health, in terms of the fundamentals of the airway development. So can you just give us a little bit of a view from an orthodontist how the idea of beauty and the dental arch forms a beautiful face, just to help us start thinking in this the way an orthodontist does?
I mean, the most beautiful face is from the healthy individual, right, at the end. And I think, like, for example, this is our everyday, everyday, how are we going to move these, faces to better, for example, the surgical planning. Okay, so there is three big dots. One, we want to have beautiful occlusion. And then we also have like a beauty component. We want to make sure my patients like a beautiful, and they want to make sure that there's an airway component. We want to make sure that our patients breathe better and healthy better. And a lot of times, if you plan properly, we get all these not two rabbit, the three rabbit togethers. Ideally, we want to get it like when our child is growing, like when they are young. We often see when they have a sick kid or they cannot breathe through their nose, we see their craniofacial structures is changing in wrong way. Like a lot of time the patient come to me and like, Dr. Audrey, I want beautiful smile. Please like straightening my crooked teeth. And often orthodontists just to focus on teeth alignment, and that's how we get trained before. But a lot of time, the teeth alignment and bone shape are telling you the stories. There is a reason they've been shaped that way. Like malocclusion can be sign of other medical conditions. It's like a tip of iceberg. So when you're actually looking at the whole patients and whole the individual, on the surface meaning, maybe it can be simple open bite, high angle, narrow high arch palate. But actually what really means in the deeper meaning, when you actually really see, the patient has been mouth breathing, there is an airway obstructions, there's abnormal tongue functions, and the patient is growing in wrong direction. That is the real message the malocclusion is telling you. So I know, a lot of orthodontists can straighten their teeth beautifully, all these cases. But if you go like one step further than like aligning teeth, what is the main root cause and there's anything we can help? Like different treatment approach maybe make difference and make my patient healthier. And a lot of time when we start early enough, we can make the face beautifully, but also we can make the teeth beautifully and the occlusion beautifully, and then also their bite beautifully. So yeah, there is a lot of like the three dots actually connecting together, and we actually approach it as a whole. I don't know, you make that answers.
No, that explains it really well. And it's amazing, this connection between how because we're talking about facial development, and the face is our tool for how we communicate, how we connect with others, and also for facial beauty as well. So it's amazing how the orthodontic growth and development is underlying these really critical parts of our human self. So I find that really interesting, and something that just doesn't get discussed very much. In terms of how we're shaping these, if we can understand the underlying issues there, can we help people to be better, not better, but express themselves the way that they're designed to. It's really interesting. I thought that we could start to dive into the patient the patient presentations that you're seeing in your practice. So for parents out there, they have children at home. What is Dr. Audrey Yun seeing in her clinic that kids are presenting today in terms of the types of malocclusions? And then later we'll go into your papers that describe a lot of these bigger questions as to why it's happening. But what are the big presentations? You mentioned a couple there that kids are experiencing in terms of their dental arch development today.
So maybe it actually, that's why I came up with the 6 flag papers. It's not out yet. It's actually it's going to publish the next week in the Pediatric Dentistry Journal, and it's very exciting because I know Pediatric Dentistry Society is very, very conservative in the past, and they're really hard to publish in that journal. But once you get published, now become a standard. So I'm actually very excited to our paper because like dental professionals need to play a key role in recognizing this disorder, because we tend to be in contact with our patients and parents more frequently than other health professionals. And we are dealing with this like dynamic oral structures that affect vital functions like taste, speech, mastication, swallowing, and oral hygiene and breathing disorders. And dysfunction also related to alter the skeletal jaw development and dental malocclusion during child. And it's important because this maxillofacial skeleton define the foundation and dimension and the patency of the nasal and oropharyngeal airway. And all the identification of these influencing factors will create opportunity to modify their facial phenotype at a younger age and make our patient healthier for the rest of their life. And if like it's very simple, like a red flag you recognize, and then you actually talk to their parents, even their young age, and then we educate them what to look for. And that those like a red flag, if there is a red flag present, that really kind of raise the awareness even for the parents, so that we can see. So I mean, the common sign and symptoms is, as snoring, some mouth breathings. And these days, like a lot of my patients have ADHDs, or they have a tempers, or like I have a lot of them is the autisms, and those like a kind of common sign as well. But in this paper, we also developed to identify like functional and like kind of extraoral and intraoral features associated with this increased risk of sleep disturbance. And we wanted to develop the very like functional airway screening tool, very simple. Like you just look at the 6 factors and then see if there's anything. So we found the 6 red flags for pediatric dentists during our like a routine dental exam. And there's 6 red flags. One is the large tonsils, and then another one is mouth breathing. And another one is a difficulty in closing lip together. So we call mental strain, where the kids cannot close their mouth, and also look for tongue tie. And if there is a high narrow arch palate, and dental wear. So this is 6 red flags you can clinically you see for the patient's kid's mouth. And if there is like 0 to 1 red flag, then you have low risk of sleep disorder breathing. If you have 2 or 3 of these red flags, then you have mildly increased the risk of sleep disorder breathing. If the kid has 4 to 5 red flags, there is a moderate increase of risk of sleep disorder breathing. And if your kid has all 6 flags, the patient has a super higher risk of sleep disorder breathing, and you need to really look for additional helps. So we found a very simple 6 flags, and then we came up with a very simple and easy and kind of clinical, finding that even parents, or you can educate even caregiver easily to kind of identify early enough.
What age groups would you say that this is ideally applied in? And are there different presentations through the different developmental periods in terms of how parents and practitioners should be thinking about when to identify these issues?
Yeah, so I'm sure so this is the area that we need like a lot of research. The 6 flags and that paper based on our mixed dentition age group. So we got our data from 100 mixed dentition, the pediatric patient who came to UCLA pediatric dentistry. But if you looking for younger child, of course, they are too young to develop the mental strain and stuff. So when you're young, also, that is another thing. There was a little question that how you're going to approach the tongue ties and expansions, and of course there's that's my ultimate goal, to establish the growth modification protocol from very, very young age to all ages. But when you're like a newborn, you have to see their breathing, their like mouth breathing. They actually tongue ties play very important role. You actually see how even their sleep positions, like we call child pose under yoga. Like you put your butt up and then you just like you put your butt up and then you just go to the side. Your kid is sleeping with a very extended neck, there is a reason your kid actually sleep that way. Maybe they position themselves to breathe better. So you have to really look for their breathings and the sleep positions, and then also see, there is any obstructions, like tonsils, or you also look at, tongue ties, those like for the more younger child. And then once the child develop, you need to really see their behaviors. I think the attention deficit, or they are still they're wetting their bed. Those like more for toddler to the mixed dentition age. I think the one we came up with is a little bit more older age, like more mixed dentition age.
Yeah, and as you say, this is all being currently created at the moment. So there will hopefully be, and at the rate you're going, it won't be too long before it's together. But the this is a picture that is very kind of multidimensional, from the growth and development. Right from a newborn, there are little signs that we can pick up, and some of the signs in your paper can be picked up quite early, and then others will show up later. And so you said the mixed dentition, which is between 6 and 11. That's the kind of the age group that that parents will be that your paper focused on, and parents can pick this up too. The paper describes the Guillemeau musculoskeletal hypothesis, and this is the idea that our habits shape the dental arch. Can you describe that, and maybe kind of compare that to a more classical view of why crooked teeth occur?
So, I just tell my patients, and the same thing, that my patient comes to my dental office, and they usually have those presentations. I wish I can have maybe some example. So our bone and cranial structures like to grow from the even pressure, so we call neutral zone. So our teeth like to be in the neutral zone, where there is the outer pressures, outer force, and the inner force kind of neutralize. So for example, like a typical, when we look at their mouth and also the jaw structures, if they have a narrow arch, so our upper arch dentition supposed to be in between the tongue pressures from inside, and then cheek pressure, we call buccinator muscle, from outside. So often, if you have to be mouth breather, or you have some kind of tongue functions, so maybe everybody can put their tongue to the roof of your mouth, and your tongue supposed to support your palate. That's how we naturally develop the palate, and that's this natural expander of our palate. But if you try to put your tongue and try to breathe through your mouth, you can't, right? So somehow you are mouth breathing. It can be you have big adenoid. It can be from big tonsils. It can be nasal obstruction from crooked septums. It can be allergy, asthma, or it can be simple habit, like when they have like thumb sucking habit or pacifier for a long time. They lose the balance, and the tongue cannot really go to the roof of your mouth, because you have to breathe through the mouth, and your tongue posture goes down. You lose the support from inside, from the tongue. And in order to swallow now, in order to create the proper negative pressure to swallow, tongue usually come forward. A lot of people say tongue thrust habit, and push their tongue forward in order to create the seal. Now you are using a lot of buccinator muscle and your limb muscle. So you use some other muscle to make your shape, like your dental arch shape. So often those patients I see, that their upper and lower dental arch is kind of collapsed. And if the tongue decide to adapt to the forward, and then we actually often see the open bite. And now that swallowing pattern doesn't really have proper seals. So often the patients get some stomach issues. Like for the young kid, they cannot really digest properly, or they cannot really chew properly. And then also that affect the speech, because your air is leaking when you try to do the speech. And then now it's become like a vicious cycle. So now you don't have proper structures. And now even though your tongue tried to swallow properly, they cannot really go properly, and then it just become worse and worse. And we actually see them very often. And whenever I see these like malocclusions, like open bite or even spacings, and we have to really see what is the root cause. And a lot of time is their functions, and a lot of time is their muscle functions, their airways, and those like the maladapted their tongue functions.
You know, it's interesting because these presentations are so common now. It's to begin to start to think about what, you know, where they all start is quite you know, it's quite a big thing to be trying to comprehend, because you mentioned behaviors like a pacifier or a, you know, maybe thumb sucking in an infant to toddler. These habits can obviously, you know, prime a young child to these oral dysfunctions that do affect how their jaw grows. How would you say that these early periods, so like breastfeeding and pacifier use, is affecting the growth and development of the arch later down the track? I mean, so when you describe an open bite, just so that people know at home, that's where the teeth don't meet at the front. So these earlier habits, they really are shaping how a child is growing and developing later on. Why do you think it's so common today that we don't have this tongue posture? Because to me, I see it all the time. It's nearly every kid. What do you think is the missing link there? What has happened that has stopped these tongues sealing to the roof of the mouth?
So I think that's your specialty, right? There is a lot of diet. There is a dental diet issues. I think we are evolving too, and also I think allergy play a very important role. I think almost like now is half of population have some kind of food allergy or environmental allergy or seasonal allergy, and even I recently developed the allergy. So I think the allergy really play important role, and which actually make our job really hard, because even though we try to make the structure really wide and we do everything myofunctional therapy and stuff, but the kids has a chronic allergy. I mean, sometimes they have to breathe through their mouth to survive. So I think allergy, I think that is a whole, like allergy and asthma, that is a whole the new area they need to actually digging in. And that's actually one of those like really non-responder responding those population for our conventional the treatment. There's huge allergic populations, and I don't know. I mean, there are so many the new environment. I don't know. We are evolving. It's because of diet. But by the way, the changing diet also change huge. Like I've seen a lot of by my kid to change their diet, like and then their inflammation goes down. So that is actually the whole area that we need a lot of evidence as well. But yeah, I see them all the time. You're right. It's a lot of time. It's not disease. It's hard to say it's a disease. It's like a pandemic. Everybody has it.
It's true. It's just, and really the message out there for parents is that, you're not alone in this whole situation, because so many kids today are really struggling with this problem. One of the big issues that you've looked at, and also too that parents will see, is the poor sleep. And you mentioned some sleep posture issues. So kids that sleep on their stomach, or kids sleep with their legs up, and also their neck extended because they're trying to open their airway. What about when we get into the older ages, or a little bit older, when the dentition is through, and we experience sleep bruxism? You've written a paper on some of the hypothesized causes of sleep bruxism, or co-authored a paper, and it's at the moment, we don't have a direct definition, do we, as to why bruxism happens? So teeth grinding in kids. Can you help parents to understand what bruxism is and how we're beginning to understand the connection to sleep and what's actually happening and some of the signs that you picked up that are
So,
associated with
yeah,
teeth grinding?
bruxism is another big gray area and like a very controversial area, and that's why I wanted to dig into the more research. So far, there's very little we know. So I mean, bruxism is basically, we can say, it's a grinding, and they have different bruxisms. So when we say bruxism, there is a possible bruxism, and they have probable bruxism, and they have definite bruxisms. So possible bruxism is more like a self-reported. The patient say, I'm grinding my teeth, is called possible bruxism. So because we don't know. Probable bruxism is the patient say, I'm grinding. Plus, you see some kind of clinical finding. There is like a dental wear. So you kind of flat surface of the teeth, and the patient or parents that they grind their teeth, then is called probable bruxism. And definite bruxism is based on all three factors. It's a self-reported, and then clinical exam, and then also you need to have those we call polysomnographic recording. It's basically, we actually have the audio video recording while you are sleeping, and then see they're actually literally grinding. And the bruxism, especially in children, is super common. Depending on the research paper, it can be like 5% to 50%. So it's like huge variable. And like, I have a lot of those parents say, okay, my son is grinding their teeth a lot, and what can you do? And so far, current treatment modality in pediatric dentistry is only like limited in focusing on the consequences of bruxism, which is you have the dental wear, and now we put some occlusal splint, or we do the dental restorations to restore. But even then, it's those mixed dentitions, like they keep changing their dentition. It's even occlusal splint is not often recommended, because it's not going to fit in a month. But we really don't quite understand the associated factors. We roughly thinking that there's three big reasons. The most important reason is a sleep disturbance. So we think that somehow their airway is affecting during their sleep. Some kids are kicking their legs, so we call it rest leg syndrome. And then some people grind their teeth, so we call restless jaw syndrome, like we call the bruxism. But the most common reason they grind their teeth is they somehow get the sleep disturbance. Also, there's a huge component. It's a psychological and physical stress. So the kids kind of grind because of a lot of psychological issues. And it's very rare, but sometimes their bite is kind of weird, especially those mixed dentition that, they lose the teeth and then they get new teeth, and only one teeth are touching, and they create a lot of interference. Kids like to kind of subconsciously grind them off to make it even, to get the proper bite. So it's rare, but sometimes they grind their teeth from those, malocclusion, but which is very rare. And sometimes it happens during the growing child. But, most likely we really don't quite understand the associated factors. There are some studies that after they remove the huge tonsils and adenoid, and it reduced their grindings. So I think there is some relationship, but we don't remove the tonsil because teeth are grinding, right? There is also a study that after palatal expansions, their grinding reduced, like the incidence of dental grinding reduced. But again, I mean, if my patients coming, they're perfectly normal, 100%, just because of I see the dental wear, that doesn't really give me enough indications to do the palatal expansions. So we really have a lot of quite unknown associated factors. That's why we did the our study. So we actually look at the probable sleep bruxism. So we asked the parent. We couldn't do the sleep study, but we asked the parent, and then we look at their teeth grinding, and then see who fall into the probable sleep bruxism group versus the control. And then we also look at a lot of clinical findings. And then what we found is there's a few factors associated with sleep bruxism. So first one was impaired nasal breathing. So if the kid cannot breathe through the nose, they tend to grind their teeth more. And the habitual mouth breather also related to sleep bruxism. And also, interestingly, if you have a restricted tongue mobility, so you have a short frenulum, they also grind their teeth. And then if you have a lot of like big tonsils, also they grind their teeth. And then out of all these factors, actually the ankylosing found to be one of the important contributing factors for the bruxism side. That was interesting. But then the more interesting thing is we split our data to nasal breathing group and mouth breathing groups. So when we look at the nasal breathing groups, very low incidence of bruxism among these nasal breather happen. But then when we look at this mouth breathing group, now the ankylosing play very important role. And if the kid has like all three factors, like mouth breathing, ankylosing, and big tonsil, pretty much everyone has a bruxism. So we found that there is a synergistic effect. So if you have mouth breathing and ankylosing and tonsillar hypertrophy, is really prone to have significant bruxism. So I thought it was very interesting. But yeah, there is a huge area that we need to, find more evidence.
It is. There's so many, obviously clinical aspects, but also to understanding the pathophysiology between all of those three factors as to why, and why we're seeing this presentation. How do you? I mean, the connection between bruxism, teeth grinding, and the airway. How do you explain, or from what you've seen, why do you think we see this association in the sleep studies between the sleep grinding and the airway issues? What do you think the body is doing in those periods during sleep?
So it's again we call restless jaw syndrome. So it's that there is a disease called restless leg syndromes. So when you really, especially for the kid, when they have the sleep disturbance, I think some kids are kicking their legs, some kids kind of moving their jaw to kind of basically wake themselves so that the airway doesn't get collapsed. I mean, that's how I usually explain to the parent easily. So when they grind their teeth in their sleep study, not necessarily shows they have obvious like oxygen desaturations or obvious apnea hypopnea index, but the kids doesn't really have a good night's sleeps, and then we get a lot of those like symptoms on the kid. So I don't know if that answers your question.
No, it did. And there is some evidence to show that if we treat the obstructive sleep apnea, the incidence of clenching goes away too.
Correct.
So
yes.
There seems to be this connection that is, and what you're saying is that there's no concrete understanding and paper.
Yeah.
Exactly
So for right now the guideline. So there's no guideline for the kids bruxism, unfortunately. But if we're looking at the adult bruxism guideline, so for the adult, if they have a severe bruxism and then they have sleep apnea, they usually treat the sleep apnea first, either like CPAP or oral appliance, and then we see if that actually reduce the bruxism first. And then, so if their bruxism reduced after you treat the sleep apnea or oral appliance or the CPAP, if not, then we thinking that is not related to sleep apnea, and then those like you use those like mouth guard. We prefer to put the mouth guard low arch than upper arch. So imagine you put the upper arch, the mouth guard, you restrict the tongue space, right? So it actually get worse a lot of times. So we actually put the mouth guard on the low arch for those the sleep patients. But for the kids, I mean, just the same thing. When the patients come to me, I cannot really guarantee that after palatal expansions, your kids maybe grind less. I have actually a huge population that they grind less and they feel better, but there is also a lot of population that they still grind their teeth. And so there is the many papers showing that after tonsillectomy, after palatal expansions, their incidence of their grinding reduced, but it's really hard. I mean, same thing as everything else, but I think eventually we want to have the perfect phenotyping that we know that which phenotypes gonna get helped by this kind of treatment. So we still don't know who is gonna respond well and who is not gonna respond well.
So you're beginning to describe some of the work that you began with Dr. Stanley Liu, who you mentioned early, who is with this Stanford Sleep Center in at the Stanford University, who really where Christian Guillemot, kind of began his journey. And it's amazing that this work is still, flowing on 30 years later. But the paper that you're involved in talked about the connection between palatal expansion, so the roof of the mouth, and the volume of the airways. Can you describe a little bit about how that paper came about and then the results that were found?
Yeah. So whenever I do the expansions, I do expansion for whole ages, from 2 years old to the adult. And people ask me how expansion works. The parents ask how expansions improve sleep apnea. So that was kind of my interest to know that how really help the patients and how actually explain and why and who is the responder and who is not responder. So I usually tell my patients that your palate is the roof of your mouth, but also flow of your nose. And our airway basically have a two airway, which is a nasal airway, which is surrounded by bone structures. So when we expand, I know I'm gonna change my bone structures for sure. But then there also we call pharyngeal airways, basically the throat airway, which is just made of 100% muscles. There's no bony structures, but the muscles is connected to our jaw, like upper and lower jaw. And when we move our jaw, those muscles can stretch. And also the tongue is one of the most airway, dilator muscles. So when we do some expansions, for sure, I know I'm going to improve the nasal obstruction because I know I'm changing my bony structures. And, the nasal obstruction is so common. It's almost like 30-40% of US population and with a varying degree. And especially for the kids, you can do adenotonsillectomy, allergy treatment, nasal spray, maybe some diet change, but there is not much treatment option for growing child because they don't do the nasal surgery like septoplasty for growing child because it affects the nasal maxillary growth. And when we do some expansions, because we change the flow of your nasal house. So when I talk to my patients, we are doing some remodeling of your nasal house. So we're giving you more square footage. So we're giving you more nasal flow, and also that actually open up the side of the nasal house. So we give you more nasal cavity volume, but volume doesn't really mean everything all the time. So we found that we call internal nasal valve. Internal nasal valve is the narrowest area of the nasal airway, and that represents about 50% of total airflow resistance. So a lot of ENT doctors, they are focused on that area, internal nasal valve. So, but nobody really look at the internal nasal valve from the expansion. So I did a 2 study, one for adult. So we used the dome technique, distraction osteogenesis expansion technique. And we also did one study for the pediatric population for the young kid. And we look at their internal nasal valve. And also we look at the expansions. And also we measure their, we call nose score, nasal obstruction scores, where how they feel much better in terms of subjective their obstruction symptoms. And we try to evaluate these expansions as a valid treatment for nasal obstructions. And actually we found that especially for the kid, when we expand, we see the diastema, the diastema correlate with the internal nasal valve angle, and we can use those as a predictor for internal nasal valve changes. And we actually found that this is a kind of decent, valid treatment for nasal obstructions. For the kid, if they cannot do any surgery and they fall into those phenotype, we can use expander as a nasal obstructions treatment. And adult, now we have a whole those Stanford Airway protocol. We put the dome surgery on the nasal surgeries. So our first effect of Airway from the expansion is we are making your nasal floor, your nasal house bigger so that you can breathe better. And we also attacking those narrowest area of nasal house so we can actually give you better airway. But also there is a secondary effect is we also making more volume for your tongue space. So what happened is, especially for the kids, about 6 months later after we expand, what happened is your tongue posture change. So now we give you more airway, we give you more space for your tongue, and your tongue can come up and forward, and that open up the pharyngeal airway. That is a secondary effect. And we actually see for the kids more often. Adult, even though we give nice structured tongue, never been there. So we actually need to do some myofunctional therapy to let the tongue know that now you have more room, you can go up and more forward and explore the new area we develop. So that is a secondary effect of your tongue posture change to open up the pharyngeal airway. And what really eventually what happened is we call PCRIT, the collapsibility of airway, because we change the airflow from the internal nasal valve area. So we actually reduce the air turbulence. So now your air breathing muscle doesn't have to work hard because there's no air turbulence. And now the tongue actually came more forward. So our airway collapsibility changed. And that's actually how expander helps for the sleep apnea. So it's like a three steps.
It's so complex, isn't it? And it seems that different people experience these issues in different ways. Like you mentioned before, the tongue tie and the potential connection between sleep bruxism. Well, these kids with these, I see the low tongue, and the tongue just doesn't come out of the throat. And sometimes they don't even have the tongue tie, and there's just this low tone in the muscle, and they just don't know how to lift the tongue up and out of the airway. It seems that there's these different presentations and you're describing how all of these factors come together to help the child breathe, during the day, and then obviously at night as well. One interesting thing you just described, I'll just explain, is that you said a diastema, which is a gap between the front teeth related to the nasal valve, and that was a measurable way that you could see if you opened up this gap in the child's tooth, that you could measure the patency of the nasal valve. That's really fascinating, isn't it? And do you think that a diastema in children should be more common today?
Oh no. The measurement of the diastema after expansions. So I think we found the correlation after we do the expansions. When we try to find the correlation, And we found the nasal valve angle change and diastema change was correlated.
Okay, got you.
Yeah, it's not natural.
I mean, so in terms of spacing in the pediatric dentition, do you think that kids should be developing more spacing? Is this something that we've lost in a way, or
We
like
lost big time. Yes. So we
yeah,
call primate space. So
yeah,
during the primary dentitions, we're supposed to have a lot of space in between. And I guess it's now everybody else, like every kid come with the no space. It's very, very common. It's very rare to see some space between the teeth. And we know that when the permanent is coming, they're gonna have a lot of crookedness on the dentitions.
and it's a great description of the bony architecture of the nasal airway, and then the muscular architecture of the nasal airway in the pharyngeal behind the throat here, and that there are two ways to kind of approach this. One that you've looked and studied and that you do in your practice, which is growing the bone in the maxilla and the roof of the mouth, but then also the myofunctional therapy, we're training the tongue to come up into the roof of the mouth. Do you find that what's the chicken and egg there? So if you train a child myofunctionally to lift the tongue to the roof of the mouth, can you see improvement? What should happen first, or what are you seeing in terms of does there need to be expansion? Obviously, each case is different and individual, but do you feel that kids need orthopedic expansion first, or do we should we be training the muscles first? And how do these work in your clinic? Do you feel that there should be one should be happening before the other?
So yeah, that's so where really we need a protocol, and then it's a lot of time is just practitioners' judgment call. I do expansion for as early as 2 years old, and I also see very biased population. My patients tend to be very sick and they need help, and they usually have a lot of other medical conditions. So we don't have time to develop, and there is usually a reason why they have already narrow hierarchy palate. So I just go and then expand it. So I think it's when I think those ages like age under 6, that is really like your judgment call. So if your kid is perfectly healthy, there is no other issues, like no speech issues, no breathing issues, and they have a little bit narrow palate, but you can actually work on your tongue. I mean, not every small kid need expansions. So for those kids, we can do more myofunctional therapy, or sometimes the kids like especially for those young kids like 2, 3, 4 years old, even though I'm pediatric dentist, I'm comfortable, but not every kid I can handle in my dental practice to put the expanders and stuff. So those kids, we actually start with the myofunctional therapy first. But for those patients that they already have those other medical conditions or mouth breathings, or when we look at whole their family, they're like mom and dad already have sleep apnea, and then we see all those like a family histories. I tend to go early to get the structures because I know I can make those structures in 2 months. And then it's so much easier. They can work on myofunctional therapy afterwards, especially when they have tongue tie and stuff. I think also different ages different, but my routine protocol is I give a structure first. I just go in and out to develop the nice structures in like 2-3 months, and then let the myofunctional therapies to work, and then we do the tongue tie release, and then we achieve the functions and I monitor. But expansion is really sometimes lifetimes, and we need to really monitor and then see when is a good time to intervene. And I think it's a lot to do is a judgment call, and we actually see their lifestyles and their parents' willingness to do some work, and also other medical conditions. There's a lot of factor to consider.
I think that's such an important point too, is that sometimes it's just not in the family's kind of, they're just not in the space to go through, because it is intense treatment, isn't it? Expanding the palate,
Right.
there's a lot on the kid, it's a lot on the family. And so sometimes it's just not, they're just not ready for it. So sometimes you make the judgment call. And yeah, I love that. What types of techniques are you mainly using for expansion? So you mentioned you started two. These are fixed expanders. Do you use removable expanders in the mixed
I get
dentistry?
this question all the time. So I tell my audience that the best expander for young child is whatever they are willing to wear. So I think when I deal with the 2, 3, 4, 5 years old, like they determine which expander they're gonna get. So but in that age, their suture is wide open. Whatever they can wear is gonna work. It's removable expander, clear liners, fixed aligners. We really have to see their family. Not every family can handle clear liner, but not every kid also can handle sitting on the chair and then I can deliver the expander and glue their mouth and then take it out and clean the glue. So really, again, it's a lot of judgment call. But one thing for sure is I do very slow expansions. Even though I use a fixed expander, I do very slow expansion during the primary dentition age. And now, actually, I'm also doing some study with the Invisalign company that we actually do some aligners. It actually is working beautifully for those autistic kids, or some the patient has a lot of other problem where they need a lot of other therapy, and or they have some hypotoning muscles or the speech issues. And as long as it's more like a parent work. As long as their parents are willing to do, it tend to work really well. And I think that is the age that we need to really focus on establishing like nasal breathing, heavy corrections, and the early growth modifications. So it's like a lot of patients and parent educations, and then collaborate with myofunctional therapists and the ENT doctors.
Absolutely, it's a complex issue that requires complex treatment modalities. You mentioned clear aligners, so these are clear aligners that are designed to grow and expand the jaw. Is that correct? Is it just
Mhm.
is it in the
Mhm.
horizontal dimensions?
Yeah.
And
So I have a lot of those family that I try every single like expander in the world, and then the kids just taking out, they can tolerate it. Like I use removable, and then you just like on the way home they throw away, But then the mom is wearing Invisalign. The kids issue is that the kids is wearing Invisalign beautifully, and I was able to expand almost like 8 millimeters in like less than 6 months. And he, the 2 years old, didn't even wear all the time. So that is the beauty of like all the expansion. Their bone is so malleable. So actually now I use those the clear liner more often. Obviously, I don't have enough data showing that they get as a skeletal expansion as the rapid palatal expanders, but that is the age that I use a slow expansion anyway, even though I use those fixed appliance. So I'm actually using more and more, and I'm actually doing more studies. So hopefully within few years, I can show you the difference and how I can get the result from those populations.
it's fascinating because like you said, it's a very difficult and delicate area dealing with young children. So I think the more techniques we have, it's just going to make this easier to access for certain families and so forth. So I think that's great that that you're
And
looking in
it's
these
actually
areas.
easiest technique ever. You just
Yeah.
need to scan and give them instead of you dealing with a crying kid on the kids, so on your dental chair. So actually, it's a win-win. It's easier for me, and then easier for the parent. They don't need to come often. Like for me, it's like my those pediatric patient treatment becomes so much easier. So if that give us a good promising result, like yeah, definitely it's a go-to. I mean, sometimes that's the only option though. Like I get a lot of those kids refer from all over the world and nobody can treat. And, like I deliver them with a line and I treat beautifully. So, uh, sometimes that's the only solution.
No, makes sense. Dr. Yun, your work has been so instrumental in helping this, these techniques and these, just the concept of understanding how the, childhood dental arch influences how a kid breathes. I think it's so important. So I want to thank you so much for that. Where do you see, or where do you hope this is in 5, maybe 10 years? What would you like to see in terms of how, we are looking and treating our children in the future?
Yeah, I mean, probably still myself, and probably with a lot more the papers and research paper. I hope I'm still accessible, and maybe I can do another interview with you in 5 years. I think our future study, our focusing is more precision medicine. Again, it's like a phenotyping. It's like instead of you just throw the expander for everyone or throw the one technique to everyone, we want to know that which technique works for each phenotypes, and we know why this patient was not responding. So we try to find the reason between the responding group and not responder group. So that is our main focus. And then my another main focus is, again, I try to convince my mainstream scholars in the different field. So hopefully this field is become mainstream field. I think it's coming. So hopefully, like this is not for the only special people do. It's actually is the standard of care for every dentist and orthodontist and like physician think alike in the future. So, but I'll be still myself the same way.
Well, I hope so, because you're such a smart, highly specialized, highly educated, and just determined person. Because the work that you do, it isn't easy, as you say. It has been a very underpublished area and a very misunderstood area. So the work you've done has been very critical in helping others to understand, how we just think about these things with our patients, and then hopefully, as you say, in the future, building protocols for parents and practitioners to really address these very, very difficult issues in children. Dr. Yun, I want to thank you so much for spending the time with us today. I do hope that we get to talk about this and all the progressions in the future, and all the best for your coming research and your clinical work. Thank you so much for spending the time with us today.
Oh, thank you so much for invitation. I really had a great time. And see you in 5 years.
See you. Bye, Dr. Yun.